How about the other important new strategy that we have on conduction system pacing? And then it's of course left bundle branch area pacing. So deep within the interventricular septum, to really start having the activation on the left side on the interventricular pacing, interventricular septum, and would be even nice is of course when you also capture the left bundle. We showed in Maastricht that in 2016 that it's actually possible to use a standard screw to go through the interventricular septum in patients and to stimulate the left side of the interventricular septum. And a year later, it was actually in China, Weijiang Huang was the first to show that it's actually possible with the standard leads that we have available. And it was performed with a 3830, a 4.1 French lead from Medtronic, to capture the left bundle on the left side of the interventricular septum. Is it then hard to really aim for the left bundle? Is it hard? Similar, if you can compare it to his bundle pacing, it looks that it's not that specific for your implantation procedure, because the left bundle is a very large, covers a very large area of the interventricular septum. So when you use a certain strategy, and also Zach Winnett will probably emphasize that more closely than I will, is that it's really not that hard to obtain capture of the left bundle on the left side of the interventricular septum. So if you start mapping from his bundle region and you go about 1 to 2 centimeters towards the apex and then penetrate the interventricular septum, you very nicely end up, if you go really to the endocardial surface of the interventricular septum, up to the left bundle, aiming for left bundle bench capture, of course. If you look at a patient with a normal ECG on the left side, this is a case I recently did in Maastricht. Of course, you see a patient with an intermediate axis, narrow QRS. If you start pacing from the right side of the interventricular septum, you have a very wide QRS with a W pattern and V1. However, as soon as you cross the interventricular septum, then again you obtain a nicely narrow QRS, but often and rather strongly is the right bundle bench block pattern that you obtain during left bundle bench capture. You see also nice on echo that the lead is really penetrating through the interventricular septum, and also in a CRT that was performed for other reasons, you see that the lead is getting really to the endocardial surface of the interventricular septum on the left side, of course. If you look at the pacing values, because we know with his bundle pacing, that's always a little bit harder. You have lower sensing value, higher pacing thresholds. Actually, with left bundle bench pattern, left bundle bench pacing, it's different. The average threshold is rather low, between 0.6, 0.7, and it remains stable over a year in this first trial. And also the R-wave sensing value is about 10 to 13, which of course is very normal for our procedures on standard routine right ventricular apex lead implantation. This is then the publication of the first 100 procedures that were performed by Pugal Vijayaraman in the US after visiting also Weijiang Huang in China, that he showed it was possible to perform permanent left bundle branch pacing in 93%, really capturing the left bundle branch in 88%. So the difference then is deep LV septum pacing, as you can see. Conduction system capture in 83%, a left bundle bench potential was seen in 63%. In those 100 patients, there was 3 dislodgements. So it seems it's rather possible to have a true left bundle bench capture on the left side by this new method of conduction system pacing. Nevertheless, you still need an EP recording system, I think, also for when you start performing these procedures, because you need to carefully look for the left bundle bench potential. You need to perform sophisticated pacing maneuvers to really define how you capture the left bundle branch. But nevertheless, also when you use it in patients with left bundle branch block, you can really obtain a very much more synchronous ventricular activation as compared to the situation in a patient with left bundle branch block. This is a patient that we get referred where they were not able to perform CRT, the routine biventricular CRT implantation. And in this patient, we started with left bundle bench pacing. And when you then perform this procedure, have a lead on the left side, capturing the left bundle, you already see a much more narrow QRS with this typical R prime indicated that there's some delay in the right ventricle because of the capturing of the left bundle and in indirect right bundle bench block. However, of course, with the intact AV conduction, you can fuse then intrinsic activation via the right bundle together with left bundle bench pacing, and then you can obtain a very nice synchronous narrow QRS in your patient with heart failure and underlying left bundle bench block. But what are then still the considerations in left bundle branch area pacing? I think it's still good to really think about this before you perform it. We have, although it looks very promising, we have higher ventricular sensing values and lower pacing thresholds as compared to his bundle branch pacing, and backup lead is absolutely not necessary. There's still some considerations. You need an EP recording system. I think it's still not possible to capture left bundle branch in about 25% of your patients. And nevertheless, the definition is still not 100% clear when you clearly have left bundle branch capture. One of the things though is really troublesome sometimes is patients would have a thickened interventricular septum, especially in LVH, ACM patients, and septal fibrosis. It's sometimes hard to really get through the interventricular septum. Whether we truly need to capture the left bundle or whether deep LV septum pacing is actually good enough is still unknown. And I think that's important to make the next step to get it more widely distributed, this new technique. We don't know what the effect of this pseudo right bundle branch block area, right bundle branch block is in our patients who get left bundle branch area pacing, especially in patients, of course, with heart failure. What's then the role of this delayed activation of the right ventricle? So we really need larger randomized trials to confirm that it's really additional value for our patients. So, and of course, there's no experience with long-term lead survival, and what is often a question, what can we do with extraction of the lead? Is it hard to get the lead out when you have penetrated the septum for over a centimeter? So to conclude, I think both techniques are very promising, and we should really focus on this new technique because I really think they can bring us further, and they really have the possibility to obtain resynchronization with a single ventricular pacing lead. However, we need more studies and especially more prospective and randomized trials to show that it's really of value to our patients. So I think it's not prime time yet, although we should really focus on this new area to bring us further.